so we can make sure that we cover those areas. So I would now like to move into the presentations and would like to introduce you to our first speaker, who is Dr. Michelle Funk. Dr. Funk is the unit head of WHO Policy, Law and Human Rights team. She leads the WHO Quality Rights Initiative, which builds capacity for stakeholders to understand and promote human rights and recovery approaches, and supports countries to develop services, policies and laws in line with international human rights standards. So Dr. Funk, the virtual room is yours.
Thank you very much. I'm just wondering if you could put on the title slide for my presentation. So first of all, I'd like to thank very much the Association of Mental Health Providers and Keyring Living Support Networks for inviting me to deliver some opening remarks at this panel discussion. I'm going to focus my remarks on the new World Health Organization's guidance on community mental health services that we recently launched on the 10th of June. But first to say that I'm delighted to be joined in this panel by many colleagues whose services are represented in the new WHO guidance. They represent services from diverse parts of the world, but services which provide learning and good practice relevant to countries at all income levels. And the reason for creating these documents is simple. We know that mental health services in countries around the world are failing people, and in many cases are also contributing to extensive and wide-ranging violations and discrimination experienced by people with mental health conditions and psychosocial disabilities. So we really urgently need a new paradigm for service delivery that is focused on a person-centered and human rights-based approach. I'm just wondering if you could show my slides. Yeah, so thank you very much. So now just a few words about the guidance itself. The new WHO guidance aims to firstly inform all stakeholders of the benefits of the community mental health services that respect rights and focus on recovery. Secondly, demonstrate that it is possible to develop rights-based community mental health services that achieve good health outcomes. And thirdly, it aims to inspire policymakers and those responsible for service development to develop or scale up these services and provide the required know-how to do so. Next slide, thanks. The WHO guidance is made up of several different documents. Firstly, we have an overall document which sets a global context, outlines the key international human rights standards for which countries have obligations to meet, particularly in relation to the Convention on the Rights of Persons with Disabilities, the CRPD, as well as the recovery approach, and provides dedicated sections summarizing the 28 good practice services which we showcase in the guidance as respecting key rights and the recovery approach. The overall document then also explains the steps needed to move towards holistic service provision, taking into account housing, education, employment, and social protection. And it also presents specific recommendations and action steps for integrating person-centered and rights-based services into health and social sectors. Next slide. Aside from this overall guidance document, there are also 7 supporting technical packages which readers can refer to if they want to gain a more in-depth understanding of each of the services outlined in the overall document. The technical packages are organized by different service categories. So there are separate packages which include the good practice examples for crisis services, hospital-based services, community mental health centers, peer support services, community outreach services, supported living services, and comprehensive service networks. And this latter technical package highlights countries and regions that have put in place a combination of services from the categories that I've just mentioned to form a comprehensive mental health network, which interfaces with the social sector. Within each technical package, readers are going to find detailed descriptions of each good practice service and how they operate, a discussion on practical challenges faced by the services and also the solutions they put in place to address these challenges as they evolved. And each technical package concludes by presenting a series of action steps for people wishing to set up a similar service in their country. Next slide, thanks. On this slide, you see each of the 28 showcase services in the WHO guidance listed according to the different service category or the type of service. And here it's important to just take note that no service fits perfectly and uniquely under one category, since they undertake a multitude of functions that touch upon one or more of the other categories. And we've been sure to reflect that at the start of each of the service descriptions. Next slide. So what do all these services have in common? They are united in several different ways. So each of the services was selected because it met a number of specific criteria promoting respect for the rights of people using the services. Specifically, we're talking about services that respect people's legal capacity, their choices and decisions about their treatment, care, and support, services that implement strategies to end the use of coercive practices such as seclusion and restraint, as well as any form of physical, sexual, and emotional abuse, which we see far too frequently in the services. We're also talking about services that don't isolate or exclude, but rather that actively involve and include people in the community and in how the services themselves are run. Services that also promote community inclusion by linking people to relevant community services and support, such as social protection and disability benefits, housing, employment opportunities, and so on. And finally, we're talking about services that provide person-centered holistic care, addressing all important areas of a person's life, including relationships, work, family, and education, rather than focusing solely on diagnosis, medication, and symptom reduction. Next slide. As I mentioned earlier, there are a number of key recommendations made in this new WHO guidance, and these recommendations can be found in the overall guidance document. The recommendations specify key action steps for countries to ensure that rights-based community mental health services are integrated into mental health and social care systems in low, middle, and high-income countries. For example, there needs to be real political commitment, and alongside that, an increase in funding for developing and scaling up these rights-based services. Legal and policy frameworks need to be put in place at national level that align with international human rights standards to ensure that the foundation of mental health services are respectful of human rights. Training on human rights, person-centered, recovery-oriented approaches need to be integrated into health, mental health, and social work, undergraduate and graduate course curricula. Data needs to be collected at national and service levels on health and social outcomes for people using rights-oriented community-based mental health services compared with traditional services. Funding needs to be increased for research related to community-based mental health services using a rights-based approach. And importantly, organizations of people with psychosocial disabilities need to be actively engaged as advisors on policy planning, legislation, and service development. Next slide, thank you. So I'll now hand back to Kathy Roberts, and I want to thank you so much for this opportunity and for holding this panel discussion. Thank you again.
Thank you so much, Dr. Funk, for that. This is a really important report from WHO, and we do know from the work with our members in the UK, it is possible to develop mental health services that promote human rights and focused on recovery. So thank you for opening this webinar today. I would now like to hear from the first of our 6 good practice examples as we head over. So we're going to head over to India, Home Again is a residential supported living service which promotes mental health, housing and supported service options for people with mental health conditions and psychosocial needs. From small beginnings in a rented house for 30 persons, it is now serves millions of people and has rural and urban operations in 3 states in India. So I want to welcome Sally and Pallavi. Over to you two.
Thank you, Kathy. I am Pallavi, and my colleague Salik is on as well. I am the executive director at the Banyan, and Salik is the lead for the Kerala chapter. So I thought we would start with a little, if I could have the next slide, please. With a little background on who we are. We were started in 1993 as a crisis intervention center for homeless women with mental illness. But over the course of the last several decades, we have now expanded to all persons, not just women, who suffer from homelessness and mental illness. And we function across 3 states in India, which is Kerala, Tamil Nadu, and Maharashtra. Our focus has always been a holistic approach, which begins with, access to care, access to rehabilitation in communities, access to aftercare, and access to community-based grassroots level help and care for homeless persons with mental illness. So far, we have serviced about 1 million low-income households across India. Next slide, please. So as I was saying, that our approach is very dynamic and all-encompassing, and we try to ensure that there's continued care for the persons that we treat, for our clients. This includes, of course, one of the key elements is community living, which is Home Again, which is what we will be focusing on today. Next slide. So I thought we would start with a slightly informal concept of discussing what is a home. What is a home to me? To me, a home is my dog, my daughter, hustle, bustle, getting guests over. Salik may have other ideas of what a home is to him. And the point being that, what a home means to you and me is what a home means to anybody else, whether or not they suffer from mental illness. So really, Home Again is more than a structure, it is an emotion. Next slide, please. So before, I thought I would give you an overall idea of what the structure is. Before we begin with how it's impacted us and how impact done. Next slide, please. So as Kathy had mentioned, it's basically individuals who have no exit pathways and nowhere to go and suffer from mental illness and the stigma associated with it. Home Again offers a shared housing. So, it sort of encourages the concept of formed families. So 4 to 5 people, and this could be men or women, who live together as a family. And several of them actually refer to each other as, Amma, Tata, which, these are Indian words for aunt, uncle, sister. So these individuals live in mental illness. They have access to support and bespoke treatment packages, which includes, which is not simply medication. It is also integration, interaction, social mixing. Basically being who you are, just like anybody else. Moving on to the next slide, please. So here I want to give you the sort of the structure, but I would rather you not focus on the structure and sort of try to sort of pull out from the structure the essence of what it is. So effectively, what happens is there's a multidisciplinary team that works to support these individuals who are living in these homes. These homes typically have about 4 to 5 people, and we hire and train what we call personal assistants. These are non-technical, non-specialist people who are not trained in or possibly have no background. However, they are part of that community. We train them and the capacity building to help them understand the issues of mental health and to be emotional support to these clients. We also have, at the parties, personal assistants, people who are care coordinators, who work across 4 or 5 homes in the neighborhood that these home again in the neighborhood. And one of the important aspects of home again really is that it promotes a lot of social mixing. The reason we choose personal assistants from that community is because it sort of helps in reintegrating these people with the neighbors, making sure there's a temple nearby, a bank they can go to, helping them reclaim their lives with the everyday simple activities that you and I probably don't even think about, just going to buy a packet of biscuits or going to the temple or a mosque or whatever works for you, whatever your inclination is. So we really support individual choice in this whole program, and we also then offer outpatient psychiatric meetings so that access to medication, access to livelihood. So a large and important element of home is that we acknowledge that every individual has the right to live as they wish, whether it is an elderly aunt who just wants to relax and be, and is retired and she just wants to stay at home, and that's absolutely fine. That's your choice. Or if somebody wants to go out there and make a living, what is their inclination? What is their interest in? We work with the individuals to understand where they wish to be and where they wish to go in their personal journey, and try to facilitate access to things that allow them to do that. Next slide, please. So currently we are in 3 states across India, which is Tamil Nadu, Kerala, and Maharashtra. We have about 49 homes, 242 service users, and several of these are actually peer-led homes. When I say peer-led homes, these have been former service users who have reclaimed their lives, have attained financial independence, belief in themselves really, and have become personal assistants themselves or run the entire homes entirely on their own with some limited support from us. So next slide, please. So what I thought would be a nice way to actually give you a perspective on what home again is and what Salik and I both thought was to actually take you through some of the stories. So for impact, of course I can list it out and say, there's reduction in stigma, there's increase in neurodiversity, there's challenges to gender stereotypes. And so I thought it would be interesting for us to actually walk you through a few of the stories. All photographs have been used with permission. And I will invite Salik now to tell us about Sindhu Beach, which is a beautiful romance.
Thank you for a wonderful opportunity to share the phenomenal experiences that we are privileged to witness. Here is Mr. Sudhish and Sindhu, who are our home again residents. Sudhish comes from the northern Kerala, while Sindhu comes from the southern Kerala. They were living in 2 different organizations for more than a decade in 2 different institutions. The home again has brought them together. The home again concept has provided them an opportunity to come together. So in a way, in short, district called Malappuram in Kerala, while Sudhish used to go to hospital to access mental health care. At last time when he got admitted into the mental health center, both he with his mother passed away, and hence he had no place to go back. So he was, was living in the institution for care of him. This is a home again he joined, and both Sindhu and Sudhish had chance to meet at their common places, at their recreational places, at their vocational training units, wherever the social platform that given them chances to meet. In the process, slowly, steadily, they were in love, and it is in last year, amidst of lockdown, all of them got married, and now the home that Suthish's mother left behind is renovated by the community support, and Sindhu is joining him, and both Sindhu and Sudhish are living at the house that in fact his mother has set up, and we are sure that his mother will be happy watching them from the sky. And yeah, so this is a story in short.
Next slide, please. This is a story that is actually very close to the entire Banyan family, honestly. So Janaki and Emily are, Janaki is a trained nurse, and she was found wandering on the streets of Chennai, really far from her own village. She was disoriented and was diagnosed with schizophrenia. She actually, she's one of those people who actually entered the Banyan sort of continuum of care and had a complete recovery. She went back to her village where her sister was residing, Amili, who lives in a village called, in a district called Trichy in Tamil Nadu. And, if you ever have a conversation with them, you realize that they both sort of went back to the community that had in some ways rejected them, assimilated back, became meaningful members of the community, and they felt that they wanted to do something that to return or to help others who suffered as they did. And now they run 9 homes. They head the Home Again chapter in Trichy completely. They both have sort of build relationships with the community and gotten the respect of the community, that they are no longer treated as persons who have mental illness, but in fact as peer leaders, as persons who sort of incite the same level of good and bad, just like you and I do. They, in terms of building relationships, they have conflict, they have friendships, they have things that they can do in the community, and this is as any other person, so who may or may not have mental health issues. So they are one of our inspirations. We aspire more of our users and service users to become peer leaders, peer advocates, and be out there and grow this community. Next slide. Sally, if you want to.
Yeah, in short, quickly, the person in right, Mr. Ambedkar, born into a situation where he had to witness his mom was committing suicide, and then slowly he was ostracized from the community. But for almost 15 years, locally wandering, and the opportunity that Home Again brought, he joined voluntarily in the Home Again. Now he feels secure and safety in the Home Again. He built more friends and community supports, and he's engaging. Here is Sheba, is a dancer who has masters in dancing, especially Bharatanatyam, who used to be in an institution for years and left her family behind. Her family, her husband and kids left her while she was ill and were not in a position to manage at home at that particular time, but at the moment she's doing good, and she found hope, and she wants to reclaim, and she wants to rebuild her skills, and she is now in the process of setting up a dance school, which she resume initiate. Yeah, so she is now having a school where the kids start coming, and she's the trainer, and she's the professional dancer. Yeah, such many stories are there, and the time, of course, limits us from sharing more.
So, yeah, just to conclude, I want to say that, Home Again is really creating respect for an equitable society, and, understanding, and even at the most grassroots level, where stigma is highest, we won't go into the other stories now, to understand that people everywhere are able to accept and understand mental health issues, when they live in a community where they see such persons functioning, working, just as you and I do. And we hope to take Home Again all over the world and hopefully build a more equitable world. Thank you.
Thank you both so very much. A pioneering service in India, which brings around a much needed focus on the wider determinants of poor health. And it's a great example of how you've worked collaboratively with other organisations and sectors in India and how you've expanded your reach over the years. So thank you both so much for presenting today. I'm so sorry we don't have more time for each one, but thank you so much. Next we'll hear from Dr. Walter Garkley and Christine Clare from Sotira, Switzerland. This service seeks to offer an integrated care approach for people living through an episode of enhanced psychosis in an environment that produces as little stress as possible. So over to you both.
Thank you very much, Kathy. Dania, could you put on my first slide? Thank you very much. Okay, hello everybody out there. We are very happy to have been invited to this conference and getting the chance to share some ideas about Sotira Bern with you. That's Christine Clare, who is sitting next to me here. She's the deputy manager and milieu therapist for more than 10 years now in Sotira Bern, and my name is Walter Gekle. I'm the medical director and since 2.5 years now, and I know Sotira Bern since 1991 when I came to Switzerland. Actually, I came to Switzerland because I wanted to work there, and now the circle has come round. So could you give me the next slide, please? Okay, Sotira Bern has actually its roots in California, where Lauren Mosher founded the first Sotira house in 1971. In the framework of the then anti-psychiatric movement in the US. Next slide, please. And Lutz Ciompi took up this idea quite a bit later. In 1984, he founded the Sotira Bern in this building in which we are still today. So next slide, please. There are important differences between Mosher's Sotira in California and Ciompi's Sotira in Bern. Ciompi's Sotira was always within the medical treatment system and was situated in the sort of moderate social psychiatric sector of it, as in contrast to Mosher's Sotira, which was clearly anti-psychiatric and quite radical. That's also the reason that only 50% of our staff is non-professional. You can also say only 50% is professional, but in Mosher's Sotira, 100% of the staff was non-professional. The therapeutic community and the milieu therapy are still core elements of the treatment, but we also use medication when patients or users, as we call them, agree to it. And we have added to the mere being with in Mosher's Sotira the intensive one-to-one treatment in the so-called soft room. Christina will tell you something about that later. So next slide, please. People who are using the Sotira service here in Bern are usually suffering from an acute psychotic episode, mostly in the framework of schizophrenia. But sometimes they suffer from an adolescent or developmental crisis with psychotic symptoms. They are usually between 16 and 40 years old, and they cannot come to Sotira Bern when they are suffering from a severe substance abuse, uncontainable suicidal ideation, even not in a one-to-one situation containable, and aggressive or disorganized behavior. And the service is financed by the Swiss health insurance system. Next slide, please. Thank you. The most important thing about Sotira Bern is what users say about their treatment there. And they find it much, much quieter than a hospital ward because it's smaller. We only have 10 patients at a time. So, and users say also that the being with in a one-to-one situation is such a big difference to isolation and seclusion in traditional psychiatric hospitals. They do not feel locked up because all levels of treatment are based on consent. So The regular normal house in town, as you have seen it before, provides a no stigma surrounding, which is highly estimated by the users, and even more so the individual rooms. They can go into their room, they can close the door when it's getting too much outside in the group. So sometimes there are situations when there are just too many psychotic symptoms around. So they can close the door and nobody comes in there without knocking on the door and waiting their sign to allow them in. So they suffer from less boredom than on traditional wards, because in Soteria Ben there is always something to do in the household, in the garden, playing with the others, and they suffer also less flooding of emotions or thoughts, because they don't have to take part in huge group therapy sessions which last an hour or even more. So it's a very individual approach, and the users feel that their self-responsibility is strengthened. They can stay up to 3 months in Soteria Bern. Mostly they leave after 6 or 8 weeks, and therefore they suffer much less pressure. And the cooperation with the outside world, which is like school, employer, insurance companies, is very important to them. So please, the next slide. And the teams, we have spent some half a day nearly to define what we think about what Soteria is. And the team thinks that Soteria is an alternative treatment approach for people in an acute psychotic crisis in a not restrictive environment. And it's authentically lived relations in a family-like, stimulus-reduced surrounding. And being with users going through an acute psychotic crisis in a one-to-one situation in the soft room is a core element of the treatment approach, as it is the intense milieu therapy around the clock with involvement of all relevant others if possible. And last but not least, Soteria is a place for a self-determined individual recovery path. And please offer me the next slide. So this is a view in the so-called soft room. I think you see the difference to a usual hospital room. And now I will hand over to Christine, who will tell you what happens in there.
Hey everybody, here you see the soft room. The so-called soft room is a large, quiet and bright room with 2 beds. The one-to-one accompaniment is possible if necessary over 24 hours. The stay in the soft room should allow a soft landing in psychosis. Soteria is an old house. You can hear the everyday sounds very well. Residents clean the staircase, cooking noises, the phone rings, steps, voices, the cat begs loudly for food. In the soft room, these noises convey that there is an everyday life outside. Stimulus shielding and calming in the soft room are the most important treatment elements in the first phase of psychosis treatment. Conveying security, calm, confidence, and trust is central in this phase. Next slide, please. A caregiver is available around the clock, is simply attentive and empathic, conveys hope and confidence. Next slide, please. In the second phase, participation in everyday life is possible again step by step. Living together is similar to a shared apartment or a community. In the weekly treatment conference, the concerns and wishes of the users are taken up and discussed. The relatives are part of the treatment from the beginning. Next slide, please. In the phase 3 is about preparing for the time after Soteria, where school or work experiments are already possible. Next slide, Walter will explain the spreading out of Soteria in the whole world. Thank you.
So this is the last slide, and we want just to let you know that we're not alone anymore. There are a couple of soterias scattered across the world, mostly in Europe, but also in other parts of the world, Tokyo, Jerusalem, and even the UK. We hope to open a second soteria here in Switzerland within the coming year. Thank you very much for your attention.
Thank you.
Thank you so much, Walter and Christine, for your presentation. As an organisation that works with voluntary and community sector in the UK, we realise how important it is to provide a care and support in an environment that's conducive to good mental health and well-being. And your work really highlighted the significance of an integrated care approach, something we know that's very high on the agenda, the policy agenda here in England and Wales at the moment. So thank you both very much indeed. Hopefully we'll get some questions. Our third good practice example comes from New Zealand. Ross is going to tell us about Tupu Okwe, is that right, Ross? I hope my pronunciation is okay.
Kia ora, Kathy, that's good.
Thank you. Which is a service delivered by Pathways, one of New Zealand's largest NGOs, delivering services to over 6,000 people annually across many parts of New Zealand. For over 30 years, Pathways and its youth-focused services, REAL, have been delivering services aimed at enhancing the well-being of people, families and communities. So Ross, over to you.
Kia ora koutou katoa, no mai haere mai. Thank you very much for the opportunity to present some of what we've been doing for some time now in New Zealand, and it's incredibly timely for us. And the release of the World Health Organization's Quality of Rights Best Practice Guide has been really timely, because it's come at a time in New Zealand's delivery of mental health services where we're really needing to advocate much stronger for much more responsive services than what we currently kind of have and deliver, really. So great to kind of be with you all in this virtual world, and I'll try my best to stay awake because it's after midnight now, so all good. If I could have this next two slides, please. So just some very quick context for the system within which this acute alternative operates. So we have quite a significant prevalence of mental health and addiction in our communities in New Zealand. So about 1 in 5 people experience moderate distress. We have an increasing number of young people needing services and needing supports. Our suicide rates are among some of the worst for young people in the OECD countries. And we also have massive health inequities and massive mental health and addiction inequities for our Indigenous population, our Māori populations, and also the Pacific Island people who call New Zealand home as well. The burden of serious mental illness in New Zealand is reasonably significant, about 5% of the GDP of the country, and the total spend on mental health and addiction services is about 1.4 billion, but that only represents 9% of the total health spend, and the vast majority of that spend is on acute care services and inpatient services. We have in excess of about 50% of people using our mental health and addiction services probably have coexisting substance abuse challenges as well that they deal with. Traditionally, we've targeted about 3% of the population, and those are people with serious mental illness, so severe and persistent mental illnesses. And these have been delivered by government agencies, and we have quite a strong non-government organisation sector as well. Next slide, please. So in 2018, after years and years of disinvestment in mental health and addiction, the government, the current Labour government, decided to have an inquiry into mental health services. It was called He Ara Oranga. And some key recommendations from this were agreed to by government, and they have been kind of implementing a bit of an action plan in the meantime, although we see progress has been reasonably slow around some of the rights-based agenda, which we're looking at advocating stronger for. But some of the things that they wanted to see was to increase access rates so that people with mild to moderate experiences of mental illness are receiving access to services. The idea that we do want to strengthen community care, primary care, and non-government organisations social determinants are important, wellbeing promotion and prevention, and AOD harm minimization. And some of the approach to AOD harm minimization, or alcohol and other drug use, was to replace criminal sanctions for drug use with civil responses. And so we've started to see the adoption of drug and alcohol courts and the like, which is really quite great and in keeping with the agenda that we're talking about today. We're also reviewing a very archaic mental health compulsory assessment and treatment act, which allows people to be indefinitely put on a compulsory treatment order. And that also has disproportionately higher numbers of Māori on compulsory treatment orders as well. So that act is currently being reviewed and strengthened, which is great. And we now have a Mental Health and Wellbeing Commission. So next slide, please. So acute care, if you're unwell in New Zealand, we don't have a Soteria house and we don't have very many alternative options. Traditionally, acute care is delivered and run by hospitals. They're either on physical health hospital sites, and they have a combination of kind of purpose-built mental health facilities within those hospital sites, or they're actually wards within mainstream hospitals. People are mostly there under compulsion, which gets determined by capacity, and the legislation allows capacity to be fairly easily evidenced, or lack of capacity to be fairly easily evidenced. These hospital environments still use seclusion. They still have restraints occurring, so both personal restraints and also environmental restraints, such as locked seclusion rooms and locked facilities. And what we experience, or what we know, is that people often experience high levels of distress when they come into these units, and these units are equally as distressing for them. We see long lengths of stays. People get social disruption as a result of extended periods of hospitalisation. And of course, we're dealing with a population of people who have had significant traumas in their life, and these type of services re-traumatize people. So here's an example, and a lot of this media and press has come out since the release of the World Health Organization best practice report, because it focused some attention on some alternatives, and then it started to encourage investigative journalism into the state of some of our inpatient units. And you can see from these headings, and these are all been in the last month across a number of our media outlets, dilapidated mental health units are undermining care, reform of coercive treatment for mental illness long overdue. Lower Hutt, which is a community down in Wellington, our capital, mental health unit is pretty degrading. So an ombudsman, a legal representative of the Crown, went in and investigated these things and actually said they're dirty, cold, and prison-like mental health facilities, and actually we need to redesign them. And you can see in the image there, that's a seclusion room, and what a seclusion room looks like, which is hardly healing for anyone who's experiencing significant distress. So 10 years ago, next slide, we had commissioned from a local health authority the idea to set up an acute alternative in the community, and we modeled it off an approach that was being used by Recovery Innovations in Phoenix, Arizona at the time. And we engaged with them, and we learned more from them about what they had, which was called a living room attached to inpatient units. And we decided to set this up as a community alternative. The name Tupuaki is Māori for growth, regeneration, and renewal. It's actually the process of tilling your soil after you've harvested it to regenerate the soil so that you're able to regrow and renew. So we set this up. It's a 12-bed home based in a community in South Auckland, which is an area of quite high social and economic deprivation. And we set it up to be peer-led at a time when peer support in New Zealand wasn't particularly it was growing, and it was growing in its understanding, but we set it up so that the majority of the service staff in the service are peer support workers. So people who have had their own lived experience of mental illness or addiction, who have overcome that, and who have then begun to, been trained in order to use that lived experience to support others. It does have nursing cover. We deliver to peer principles and to trauma-informed care. So trauma-informed care is an incredibly important underpinning of our whole organisation, but particularly within our acute alternatives as well. It's home-like, it's community-based. There's no use of seclusion, no involuntary admission. People choose to come to Tupuaki, and they have that choice and that process. And of course, it's a a non-locked facility as well. People have the ability to have their own rooms and to be in their own rooms, and for those rooms to be locked if they're needing security and safety. However, they are not locked or prevented from having egress, you know, at any point. And so some images, if you think on what that seclusion room looks like and what our hospital inpatient units look like, this is what Tupuaki looks like. So you can see it's a large, beautiful old villa. It's beautifully furnished. It's got a sensory modulation room, so it has a sensory room that has a whole lot of different equipment and tools to provide sensory modulation. Everyone who comes in has a sensory modulation plan, and they're able to use with trained peers sensory stimuli to help them overcome feelings of distress or dysregulation that they may be feeling. And of course, everyone has their own room, as you can see there. So the critical success factors, it's an environment that shows respect, care, and aroha. Aroha is a term we use that's kind of encompassing. Good English interpretation would be love. And we find and believe, you know, people say, wow, maybe the people who use that service aren't quite as distressed, or they don't have the same degree of acuity clinically as they would do in an inpatient unit. We think actually when you go into an inpatient unit and your previous traumas are being triggered and you're being re-traumatized in the process of receiving services, then of course you're going to be heightened, you're hyper aroused, you know, your prefrontal cortex isn't doing much more rational thinking for you. You're going to be in survival mode, really. So come into an environment that shows respect, care, and aroha right from the outset, with people who are able to relate and understand and connect with you really quickly. That's going to be fairly soothing and calming pretty quickly for a lot of people, and that's certainly our experience. The peer values is another critical success factor. So we have a set of competencies, and we train our lived experience workforce to be able to practice in ways that meet these peer values. So understanding mutuality and how to respond and share your experiences in a way that's empowering. So self-determination, participation, and involvement in determining what your care looks like while you're with us. Equity, and of course hope, which is a fairly fundamental pillar of recovery, of course. I mentioned we're trauma informed as well, and I've mentioned the use of sensory modulation being an important part of it. We have RAP plans, so we use and introduce people to RAP and wellbeing plans while they're there, and they have the ability to engage in a whole range of psychosocial interventions, cultural interventions, including cultural healing practices, and also kind of physical wellbeing programs as well. And the service is incredibly whānau inclusive, so we have a whānau room, whānau family rather can stay if and when that was appropriate, and that would depend on other factors in the house at the time as well. So some outcomes just quickly before I sign off. So we've had a couple of independent evaluations for this, and we recently tried to get some research funding to actually research this model of care, because we do have another couple of examples of this type of service in New Zealand now. So we've got about 4 of them across the country, but not many. And unfortunately, we're unsuccessful in that application, recent application for it. But I totally support what Michelle was saying earlier about one of the things that's really required is to continue to invest in building an evidence base for practices and services that are actually kind of go against the status quo like these ones. So we know that we've got, for people who have used comparable kind of services, inpatient services, that they have a preference for this. We strongly encourage people to, we don't have legal advance directives here, but we strongly encourage people to have advance directives that say, if I'm unwell again, or if I'm in a state where I need an inpatient admission, I would rather be considered to go to Tupuaki. We have shorter average length of stay, so about 7 days on average than an inpatient population, which is about 21. The cost efficiency is quite significant. So it costs about $300 a night. It's a publicly funded service, but then so is our hospitals. We have a universal healthcare system. But an inpatient unit costs approximately $1,000 a night versus $300 at an acute alternative in the community. We've had a 7% 28-day readmission rate to Tupuaki compared to about a 13% in a comparable inpatient unit. And again, that readmission for people into Tupuaki is entirely by choice as well. So, and of course, there's no seclusion rooms and there's no seclusion practices. So we have 0 seclusion hours compared to about 20 seclusion events per 100,000 population in our inpatient units at an average of 36 hours secluded. And so the kind of the evaluations that we have for Tupuaki talk quite strongly to the people's experiences of it as well, which I'd also support. So I won't take up too much more time from the other presenters, and just say you're welcome to get in touch at any point if you want to know more. Ka kite anō.
Thank you so much, Ross, and please do stay till the end. I know you're probably tired, but thank you for that. It's wonderful to hear about one of the first sort of mental health and wellness services in New Zealand that provides a real alternative to hospital admission, which is essential for people needing crisis support. Love it's peer-led, trauma-informed, recovery-focused, cost-effective, and it shows what can be done. So thank you very much, Ross, for that. I know these presentations are running over a little bit, but I'm sure you would rather hear the presentations. And just to say, please do put things in the Q&A box. And if we can't get round to many questions at the end, we will ask if the presenters would be kind enough to sort of respond, and we can come back with some information for you. So thank you again, Ross. So next we'll hear from Michael Njenga from Nairobi Mind Empowerment Support Group. Some of you may have heard Michael's service at the WHO Report launch event, but just for a brief introduction, this peer support group in Kenya provides a space for people with lived experience to come together. It works within a human rights and social framework, promoting non-discrimination and full and effective participation and inclusion. So Michael, please tell us more.
Thank you very much, and it's an honor to be able to participate and contribute to this discussion. I would like to say that this is a service that we documented over a period of 2 years, and the core element was just trying to explore, of course, the link between peer support and supported decision making. But I'm just going to explain also a couple of important things about the peer support group program in the Nairobi Mind Empowerment Group. So I think the first thing I would start with is just to define within our context what we mean by peer support group. And I think for us, it means a group of people who define themselves in various ways. For example, it could be users of mental health services. Some people would want to define themselves as survivors of psychiatry, people with lived experience, and certainly, of course, others would want to define themselves as persons with psychosocial disabilities, coming together within a human rights and social setup to provide support to each other in coping with challenges that may arise in all spheres of their lives. So 2 important components in terms of the peer support program under Nairobi Mind Empowerment Group is that we adopt an all-inclusive approach. So it's just not about looking at issues of mental health, but you're looking at issues of social protection, work and employment, participation in the community. And we, of course, adopt a very non-discrimination approach. So for example, for you to attend the support group, you don't have to have any diagnosis, of a mental illness, so to speak. I think the second thing is to say that what we found is that the journey to and through peer support is not linear. Many members of the Nairobi Mind Empowerment Group has described a distinction between the place they were before peer support, the place they are during peer support, and also describe moving back and forth between these spaces. However, peers generally describe how they were before peer support and how they are now different as a result of peer support. So, for example, initially when the people are coming to the peer support, some of the key issues would be, and I quote, would be, for example, a person would say, I was isolated and alone, and this could be due to the systematic exclusion of persons with lived experiences, of course, within their communities. Others, for example, would say, if I expressed anger, others said, or they would ask, have you taken your medication? And again, that points out to the over-reliance on the biomedical approach of addressing mental distress. Others would talk about the loss of close relationship, loss of job or employment, due, of course, to issues to do with discrimination, whether in law or in practice. So one of the most important things we found about this peer support group is that peer support help advance a view of autonomy and decision-making. And many of the members, of course, were able to see peer support as a pure form of supported decision-making, of course, trying to comply with disabilities. Most importantly is that many of the members have found peer support to be important, especially during crisis and emergency decision-making moments, and an integral part of recovery-based services. And they found peer support to be a source of valuable information about an extensive range of issues, enabling persons with psychosocial disabilities or lived experiences to make informed decisions. So that's one important component. I just want to discuss a bit about the structure of our peer support group, of course, within a Kenyan context. Just to say that the Nairobi Mind Empowerment Group, for example, is registered under the Ministry of Social Services. And this is because, we look at issues from an inclusion of perspective, not just, health alone. Then the other thing is that, of course, the peer support group meetings happens once per month. So we have a trained group of people who we call peer facilitators, who are, of course, trained in human rights-based approaches to addressing, issues, for example, of how do you de-escalate a situation when a person is in a crisis. Of course, again, within an African context, most people for support will rely upon their families. So whereas majority of the members in the group would be persons with psychosocial disabilities or lived experiences, you will still have family members, of course, coming into this particular group. And the challenge sometimes is, of course, trying to address the issue of power imbalance, because when sometimes family members come, they will want to speak on behalf of people with psychosocial disabilities and lived experiences. So you really have to create, a safe space to ensure that there's no power imbalance within that particular group. And so one way of doing it is, for example, having breakout sessions where persons with psychosocial disabilities are able to have conversations in a safe space alone, away from, for example, their family members. And that we found to be important because sometimes issues of human rights violations and abuse can take place within the family. And of course, the person are not able to express themselves, even if, for example, one of their relatives who was responsible for that, they are also participating in that particular support group. Then the other important thing is to point out that the meetings are not held in hospital, because again, what initially would happen when we would hold meetings in hospitals is then, of course, the medical professionals would come in, and then, it would become like more of medical conversation, other than other important issues that the members would want to discuss. So that's important. And to point out that we only invite professionals upon the request of the members. So the thing I want to point about the principles on which these particular support groups operate, I'll just outline 3. And again, this we borrow heavily from the Convention on the Rights of Persons with Disability. Is first the issue of respect for inherent dignity, individual autonomy, including the freedom to make one's own choices. the concept of non-discrimination, that whether you have a diagnosis or not, you're free to attend, for example, the support group, and trying to see how can, for example, people with lived experiences and psychosocial disabilities can fully and effectively participate and be included in our society on an equal basis with others. Just thinking about what have been the key outcomes of this particular program, I think for us, what has been very, very important is that as a group which is highly marginalized and discriminated and excluded within our society, restoring voice, power, and choice through human right-based advocacy have been a very, very key outcome of this. So, for example, when we started the groups, you would ask a person with a psychosocial disability their name, and their family members would respond on their behalf. And of course, it takes time to start restoring the voice, power, and it's a broader thinking. It's a broader thinking around. Sorry.
Oh, sorry, Michael, you froze.
Can you hear me now?
Yes, fine, thank you.
Oh, sorry about that. So the second thing is about the shift from the over-reliance on the biomedical model of addressing mental health issues and distress, and sort of trying to develop and advocate for comprehensive community-based services, to address mental health issues, and also to see how this then intersects with the social determinants of health. I think the core element of this particular program was the connection between peer support and supported decision-making. And I will explain it briefly in 3 levels. That in the course of the peer support group with the Nairobi Mind Empowerment Group, we found that there was a relationship between supported decision-making and peer support. So on one level, there was a relationship between peer support and making, for example, decisions that have legal consequences. On another level, we found that peer support fosters agency and autonomy, which in turn boosts the exercise of legal capacity or the right of people to make their own decisions and to have those decisions respected by others. Then thirdly, excuse me, it is the issue of autonomous decision-making, that in the peer support group, peers will make a decision on their own, and they will bring it back to the group, of course, to receive feedback. But most importantly for us, the Nairobi Mind Empowerment Group and the other peer support groups that we have are building blocks to full and effective participation in the society on an equal basis with others. And this, for example, I can give a few examples, is, for example, in ensuring that they have access to government programs, both mainstream and disability specific, ensuring their participation, for example, in budget advocacy processes in Kenya, in legal and policy reforms, more so specifically around the mental health law, and building strategic relationship, for example, with the cross-disability movement and other mainstream movements. So I think that have been actually some of the core issues around the peer support group program with the Nairobi Mind Empowerment Group. Thank you very much.
Thank you so much, Michael. Peer support is incredibly important, and within the UK, with the National Health Service long-term plan and new roles, peer support workforce is one of those that there's a concentration on within National Health Service, within the hospitals setting. There is a lot within the community at the moment, and incredibly essential. So thank you for telling us about Kenya and how you're supporting the community there. Thank you. We've had some really great speakers and presentations. So I think for our 5th one, we're going to go to Keyring Living Support Networks, who have been promoting supported living services since 1990, with the mission of inspiring people to build independent lives through networks of support, connection, flexible support and skill building. Keyring are one of our members, so welcome, Karen.
Hello, and thank you so much. And I'm just loving all the previous speakers. They're a really hard act to follow, so I will do my best. So I'm going to talk about keyring networks, which are quite simply neighbourhood-based networks of people living in their own homes, connected with other people in the local area who receive support from keyring and who offer mutual support to other people in the network. Now, we don't think that people's lives should be revolving around keyring. We want people to be more independent and much less reliant on services, and that people should have friends and a life that's based around their choices. Our aim is to give people confidence to push themselves, and along the way we're celebrating with them when they achieve the goals they set themselves. So we work with teams in a number of teams in local authorities, including mental health teams, learning disability teams, substance misuse teams. But just no matter which team a person comes under, we prefer to talk to people about people and not about the labels that they might have been given. Charlie, would you mind passing on to the next slide? So we do this in a variety of ways, either by us or by involving local resources and opportunities. And we do that because we're trying to build flexible support that really fits with people's lives, that involves other people, and that really enables people to build layers of support that works for them. And our focus is on what matters to that individual. What do they want to change in their lives? What is it that we can draw on or we can do to support them to achieve those goals? And what impact is that going to make on the person's life and their future dreams? Okay, next slide. And to give you a little bit of a background, I'm going to tell you a story about Les. Les lives in the northwest of England. He's a very sociable member. He's got plenty of friends. He's also got a complex learning disability, and he's building his independence and connections. He's part of a network, but also he has some extra one-to-one support from his community enabler to help him live independently. And when Les joined us, he came from a 24-hour supported living service. So he has staff there 24 hours a day. And prior to the COVID pandemic, he'd been reducing his support and he was down to around about 7 hours a week spread over the week. However, and the great thing, Charlie, next slide, then the great thing about the network is that you're independent, you're living in your own home, but you're also connected to other people. And a network was once described to me by somebody that we supported as friends and freedom, which I think sums it up really well. So Les was loving life. However, when lockdown prevented him from socialising, it hit him really hard. During lockdown, things got very difficult for him. His routine changed. He struggled to keep motivated and he became increasingly sad. And we began to notice that Les was getting more confused. He lives independently, as I've said before, but he is well known to his neighbours. And so when he was seen leaving his flat at 6 o'clock in the morning with a bag in his hand, they knew to let keyring know about this. It was unusual behaviour. And we knew this was unusual for Les, and so we called the police to help us find him. And next slide. So Les was found. He was found safe, but he was not well. And we supported Les to attend the accident and emergency department at the local hospital. And they found that Les had psychosis. And then he stayed in the hospital for several weeks on a mental health ward. During that time, the network kicks in. So we continue to support Les during his stay, checking on his flat, bringing in personal belongings and money, making sure that he had his phone and he had data on his phone so that friends could stay in touch with him. We also started to work alongside the hospital and Les to plan for his return home. We flexed his support, so it would include meal preparation, healthcare prompting, and regular connection. We also built his digital skills, so he learned how to video call other people and his friends. So that was really important to get him thinking about when he was out of hospital and also when lockdown ends. So one of the things that I said before about our support being flexible, so when Les came out of hospital, he did have a lot more time. He came back to about 20 hours of additional support, And that again is slowly reducing because the groups and activities that Les enjoys has started up again. Okay, and we use a tool called Outcome Star. Can we go back, Charlie? We use a tool called Outcome Star to really help Les plan the journey that he wants to make. And it's a really useful visual tool, and it gives people, everybody involved, that know what they need to be doing around Les's action plan. Anyway, just to sum this up, Les, last Friday, quite a few of the Keyring members wanted to go to the pub. They wanted Les to come, and they thought about how they were going to make that happen. They didn't want staff to come along with him. So they organised a taxi for Les, and they knew he couldn't drink because of his medication, so they helped him choose non-alcoholic beer. One of the members kept Leighton, who's Les's support worker, up to date with how Les was doing, just how he was getting on. He did that by just a few texts. And the plan was that they'd be home by 8ish. In the end, it was after midnight when a very happy Les returned home. They'd had a brilliant night out. And for us at Keyring, that's what we would call a really successful outcome. Next slide. So, nights out with friends, hobbies and interests that we enjoy, a home where we can do what we like. These are the things that make a good life, and they don't need professionals to make them happen. And ignoring the experience, skills and talents of the people who receive support just creates a deficit culture. It removes people from mainstream society. It blocks their opportunities to be active citizens and to be recognised as contributors to their families, to their friendship groups, to their neighbourhoods and communities. And this approach really only offers failure and dependency. And Keyring was built on the belief that everyone has something to offer, and that belief underpins everything we do. Next slide, please. Over 30 years, we have learned so much from everybody that we have met. We've learned that people's values are much more important than their qualifications. We know that care plans never tell you about people's gifts. We know that risks are what make life exciting to live. There is always something new to learn in life, and that the whole organisation needs to be person-centred. We need to be empowering everybody and recognising the value of everybody's contributions, no matter who they are. And so finally, next slide, we know that being focused on outcomes is good for everyone, but it is also good for the public purse, which is of great interest to local authorities in the UK, I can tell you, on our website, and we could provide the link about some of the evidence that we've had to demonstrate that. But ultimately, what Keyring does is try to create an environment that offers just enough support through peer support, through volunteer support and skilled staff, but it's built upon the skills, knowledge and experience of the people that we're working with and their networks. And in the same way, we're working with many others, such as the Association for Mental Health Providers, Think Local Act Personal, Social Care Futures, and our local authority partners and our community partners, to really support and make the changes that people with lived experience are calling for from the services that they have available to them. And that is the end of my speech. I'm a little bit quick there, but I know that we're tight for time now. So thank you very much.
Thank you, Karen. And absolutely agree with the premise of your work. The more people are engaged and connected to the community, the more they can see beyond services and support. So now to our final presentation and good practice example, we head over to the USA. Very early start for our colleagues in a firehouse who will tell us about their crisis response service. A firehouse is a peer-run respite which aims to support people in distress to turn what's often described as a crisis into a learning and growth opportunity. It's open to anyone of 18 years and over who experience significant emotional and mental health distress and who believe they would benefit from a peer support environment. So over to you, Ephraim, to give the final presentation. Thank you.
Thank you, Kathy. So can I get my first couple slides up? Thank you. So this is Afia House. We are just a regular house in the community. We're based in Northampton, Massachusetts in the United States. We have up to 3 people come and stay with us at a time. Everyone who comes to stay with us has their own bedroom. Nobody shares a room. They have a lock on their door. They have access to a lockbox that they can keep their valuables safe in. And we are a very home-like environment. We want everyone who comes to stay with us to feel very much a part of the house and the community. And I should backtrack a little bit and just say that, you know, AFIA is part of a larger community, not just, you know, the Northampton, Massachusetts community, but we are a part of the Wildflower Alliance, which is formerly known as the Western Mass Recovery Learning Community. So that community that we are a part of also does a lot of other amazing things in the world. We do a lot of trainings. I'm on the training team, so we offer intentional peer support training, hearing voices training, alternatives to suicide training. We recently pioneered a new anti-oppression training. We have traveled all over the world. We have 4 resource centers that folks can come in and use. One of those centers actually has showers and laundry and a food pantry and, you know, clothing that folks can come in and get. And people can go in there and receive the same sort of support and resources that they can get at AFIA, but not in a 24-hour respite environment. We also have made films, and I'm going to actually link to our AFIA film right now in the chat box so that you'll have an opportunity to watch it later, because, you know, it's a little longer and I'm not going to play it here. But there's a lot of stuff that we're really getting into in our community and also the world. So everything that we do is all peer support, which I think can be a bit of a loaded word sometimes, but, you know, we are all coming from our own place of lived experience. So, you know, our mission was already mentioned by Kathy in the beginning, so we can skip ahead to the next slide. So why AFIA? What can we provide at AFIA? So people come to us primarily for hospital diversion. So instead of going to the hospital and being locked up and having all of your rights taken away, and perhaps coming out more traumatized than you went in, you could come to AFIA, where instead of rules, and I will add this one exception of COVID-19, we have some rules around COVID-19. They come from a higher place than us, and that's sort of how we frame it to people. But aside from COVID-19 rules, we don't really have rules. We have values, and, you know, these values are the same values that the Wildflower Alliance has. And, you know, so place to place that you go, you can expect the same sort of things within our organization. So, you know, in brief, what are these values? We value respect. We value differences of opinion, belief, culture, you know, people's appearances and way of life. We're really committed to undoing injustices, be that around racism, transphobia, homophobia, misogyny. These are all conversations that we're having on a regular basis. We're constantly, you know, learning and unlearning and interrupting all of these things in our community. And we also believe that everyone gets to make meaning out of their own experience. I'm the expert of my experience, but not the expert of yours. So when I'm speaking to someone, I'm really clear, like, hey, listen, what I would do in my life is perhaps quite different than what you would do in your life. And I can relate to the feelings that you're having right now. I think everyone can relate to the feeling of, you know, say, for example, loss, whether that's, you know, loss of a loved one, loss of power. You know, I can relate to that feeling. I may not be able to relate to your exact experience, but I can always relate to that feeling, and I can be with someone in that moment and share that. And I think a lot of what we do at AFIA is being with and really witnessing and holding someone's pain with them. And sometimes being maybe the first person who has ever heard this person's full story. because often when somebody goes to services that are traditional, their story kind of gets erased and their personhood is erased, and they become sort of like a diagnosis or, you know, something other than their humanity. And so what we're trying to do at AFIA is give room for all of that, for all of the feelings that people are having, for all of their personhood. And it's a really sacred, amazing place. I've been doing this work for 9 years now. We opened in August of 2012, so we're coming up on our anniversary. I am the last original member from the original team, and it is a very, very like close to my heart place. So folks who come to us have the freedom to come and go as they choose. All stays are completely voluntary. People can stay up to 7 nights, but if they want to leave sooner, they can absolutely leave. Sometimes people have come to us and said, hey, this isn't what I'm looking for. What I'm looking for is something more structured. Okay, that's all right. You know, like we're not going to be the place for everyone, but I do think that we're the place for a lot of people. We don't want to interrupt your life in any way. People stay with us and continue to work their jobs. They continue to see their families. They continue to go out into the community and do whatever it is that they do. We're not looking to take away from their life. We're only looking to, you know, add some support into their life if that's what they're looking for. Everything that happens at AFIA is conversation and consent-based. There is no coercion whatsoever. Everybody has to be there of their own free will. We're always checking in to make sure if somebody comes from a traditional environment, that they're not being forced to come to us, that it's their choice. We would never interact with the police unless there was, you know, an incident of violence or something to that effect. We absolutely believe that interacting with the police can be really harmful for folks who come to stay with us. So we do have a relationship with the police that if the police had to come to the house for any reason, that they would call us ahead of time so that we could let folks who are staying with us know, because we know how much trauma people have around the police. And we want to make sure that everybody who comes to stay with us is in a healing environment. Nobody who comes to us is somebody who's looking to be fixed. We're not looking to fix them. Again, we're all coming from our own place, every single one of us, and I'll talk about that more. But the ability, being able to talk openly about things, like I said, people are able to talk about their voices at AFIA. I am somebody who is a voice here, so I will share that with folks. And, you know, sometimes people want to talk about their voices and sometimes they don't, but I always ask for folks' consent before asking them, like, is this something you want to talk about? Because maybe it's not. It could be distressing, but you don't want to talk about it. People can absolutely talk about feeling like they want to die at AFIA. I often share when I'm working there about how I want to die most days of my life. And sometimes, you know, that is just enough to hear, like, wow, you feel that way? Sometimes that's just enough to like open wide this conversation. And so that is the sort of space that we're holding at AFIA. And if we want to flip to the next slide. So who works at AFIA? So like I said, everyone identifies with having lived experience. That could be with many different things. Some folks on the team may have lived without a home, have been through the mental health system, have struggled with, you know, substances, abuse, so on and so forth. And we're just all there to be able to share the wisdom that we've learned from these experiences and to be with people during these really dark and lonely times, and, you know, let them know that they're not alone. And I think that's often how people feel when they come to us. They feel like they become isolated from the world and othered. And we're looking to really create a community where everyone is welcome. So, you know, who comes to AFIA? Well, you have to be at least 18. But other than that, I could tell you that everyone comes to AFIA. We have had psychiatrists come to AFIA. We've had cops come to AFIA, and not because they were there to arrest anyone. We've had them come stay. You know, we've had people of every walk of life, every gender identity, every sexuality, every race, every age. They've come to AFIA because we are, you know, a part of the community, and that's who we're there for, everyone in the community. So if we want to move to the next slide. Oh, maybe I'm done. All right. So I am totally happy to move on because I know that I'm last and we've got other questions and answers and stuff, but I really appreciate this time and space and being able to be in touch with all of you.
Thank you very much, Latanya. Thank you for that. For telling us about the crisis response service and the different examples of services and what we can, I think it is very important, and it's a very good point to end the presentations on as well. So thank you for that. What we've done though, because we've had some fantastic presentations and we've gone over time on each, which is absolutely fine because they're absolutely spectacular. So we've actually not got time for the Q&A session that we really hope to have at the end, but I think the presentations are more important. But there's what's in the Q&A. I mean, some of it's about how can we influence statutory services in this country. Really good question. We're going to have a think about and get back. I just wanted to say, and thank you for all the presenters, and we may well come back to you on some of the responses if that's okay. I think we'll have to draw this to an end now because obviously time, but I just first of all wanted to thank the speakers who joined us from different parts of the world at different times, from their insights and experience. Phenomenal, thank you. Thank you for Charlie and Dania for pulling the webinar together today, and thank you the audience for attending. This event actually is the first of a series of events on this topic, bringing together our global colleagues. So please do continue to follow our work at the association, and also please do get in contact. There'll be contact details will be sent out. And we would like to ask some of our partners back, if that's okay, at some point to talk further, because that's absolutely brilliant. Just also to say just thank you to everybody, and I hope you have a wonderful rest of the day. And thank you for attending today. Please do feel free to put any more in the Q&A quickly and or anything in the chat. And just to say, everybody, thank you very much indeed for joining today. Thank you. Thank you all. Brilliant. Absolutely brilliant. Thank you. You can go to sleep, Ross. Thank you, Karen. I really
Thanks. Good night, all. Stay safe.
Good night, Ross. Thank you. Brilliant. Thank you.
Stay safe.
Bye.